Welcome to Dental Nachos CE on TV. We have an amazing presenter today. Before we start our CE, we have some fun and free things for you. What I have found is that people love free things, and us dentists, we really love free things. So if you would like to enter to win a $1,000 Visa gift card sponsored by Powerbox, just text POWER to 215-543-6454. Text POWER to 215-543-6454. This presentation is sponsored by my amazing friend and friends at the AAID, American Academy of Implant Dentistry. We all know here that implants are nachos, teeth are tacos, because all tacos break and become nachos. That's my joke on that. So to text to learn more about the AAID, including their upcoming event where I'm proud to be a speaker, text AAID to 215-543-6454. I am thrilled to have Dr. Matt Young, a friend for many years, present today success with single implants in the aesthetic zone. We're going to let him chat with us in just a minute. But if you would like to learn about all things implants through the Dental Nachos universe, just text implant to 215-543-6454. Now, we have many people watching in on Zoom. This is great. So if you would like free CE for watching in on this awesomeness, learning, laughing, feeling less alone, the mission of Dental Nachos, do this now. Text register to 215-543-6454. Text register to 215-543-6454. Now, I am going to stop my share and let my great friend Matt get his started, and we're going to chat for a minute or two while he's getting his screen share started. As much as I love Facebook, face-to-face CE and connections is truly what makes a difference in our dentisting lives. So definitely check out the AAID meeting. And Matt is even going to share a QR code. So Matt, before we get your CE started, just tell our community as you bring that up. You are president, El Presidente of the AAID. Once you share that slide, I know people can use the QR code here to learn more about it. My team will drop in the chat how they can. But what is some of the, top two benefits that come into the AAID, rock the dental implant world in Phoenix, Arizona this November?
Yeah, Paul, thank you very much for having me here. We're going to have a great annual meeting. We have such amazing implant CE, from implant surgery to implant restorations. You're going to learn so much on the main podium and from workshops. I also have the ability to network and meet friends and meet colleagues. And I know many times I've learned more by talking to people at lunch and at dinner than I even do during the scientific program. So it's a great way to get pumped up about implant dentistry and get you to that next level.
Totally agree with you. Well, I'm going to have an awesome time. We're going to talk more about that at the end. We're going to officially start the CE. You're welcome to press play for that if you would like. And I'll confirm that I see your first slide. Good. So looks great. You can click forward to the next one if you'd like, Matt. I'll see that. Good. Great. Awesome. Well, I'm going to let you take it away. We're officially going to start the CE. I'll be back on. You guys can ask questions in the chat and Q&A. If you see my face pop up back on, Matt, it means I'm going to ask a question mid-lecture. If not, we'll save some to the end. Have an awesome lecture with the group here.
Sounds good. Thank you very much, Paul. Well, thank you. Thank you for coming to our lecture. It's going to be a good time today. We're going to be talking about success with implants in the aesthetic zone. Thank you very much to our host, Dr. Paul Goodman, a good friend of mine, and glad to see he's able to impact so many dentists and team members as he has with my life over the years. So he's a very inspiring person. Somebody who's kept me on track, get to those next steps, and very happy to work with him today. For my disclosures, I'm currently the president of the American Academy of Implant Dentistry. We'll talk about some of the things for AAID today. I'm in private practice at Young Dental SF Group, and I'm the founder of Bay Area Implant Synergy. I don't have any commercial support for this program. Practice in downtown San Francisco, and our practice is right by Union Square, which is right on the trolley line. It's a very beautiful city. If you have the opportunity to be here, check out the city. This is our practice. I've been in San Francisco since 2007 and renovated this office in 2008. This is a very special picture for me. This is La Jolla with Dr. Nacho in 2007. So the reason this picture is significant is Dr. Goodman's world known and travels all over the place and conferences everywhere. But at this time, he really wasn't traveling that much. He was in Philadelphia, New Jersey, and he said, I haven't traveled that much. We were running the course in La Jolla, and Paul came all the way out here. It was great to see him in this context. It's a little different for those of you who watch Brady Bunch. It's like when the Brady Bunch goes to Hawaii, something really different. But I found this picture from 2007. I think Dr. Nacho still is in great shape and looks the same. So that's good. We have some great hands-on training for AAID. This is cadaveric training, which if you want to do live implant surgery, this is a great place to start, in addition to our many other workshops. And today we're going to be talking about staged implant surgery, immediate implant surgery, and guided surgery. We'll also talk about some provisionals and prototype fabrication. So again, in this, we have a patient. She has a hopeless tooth, number 9, or number 8. It's expanded down, and we can see from her x-ray, she's got an old root canal. She's got some bone loss, some internal resorption. It's very mobile. You can see from our CT scan that we have a lack of a buccal plate. Our soft tissue is good, which is great, but we have a lack of a buccal plate. So this is going to be a staged implant case where we want to build up that hard tissue. We call this a type 2 buccal plate when our soft tissue is in good shape, but we've lost some hard tissue in the area. So we want to rebuild this buccal plate. A type 1 buccal plate is where our hard tissue and soft tissue are ideal. And a type 3 buccal plate is where we've lost hard tissue and soft tissue. So this is a good indication of a type 2 buccal plate. And for me, I'm doing a staged implant approach. Graft first and then place the implant later. We have consent forms. We need consent forms for most of the procedures that we do, especially anything invasive. I can make those consent forms available to Nachos. You can reach out to Dr. Goodman, and we can get those on a portal for you. So we have our staged implant surgery. We do our extraction of the tooth. We do this atraumatically, and we want to make sure that we preserve that hard tissue and soft tissue that's still remaining. For this, we're going to use an allograft. Allograft is from human. We have the ability to regenerate our bone in an osteoconductive nature. Next, we're going to use a membrane. For this, we're going to use a collagen-based membrane. Collagen-based membranes will resorb rather than non-resorbable membranes. So we can place our allograft, our bone graft, into our socket here. We have our resorbable membrane that comes over the top here. And then we can place our resorbable membrane on the palatal aspect. And we can do our suturing over the top. This is a figure 8 suture to close this down from the palatal aspect, and we're maintaining and building our buccal bone in this area. So we're able to augment and build this back up again. For our provisional, we placed a provisional restoration on the adjacent tooth. She was unhappy with the adjacent tooth, and she wanted both of them to match when she was done. So this is a nice type of provisional. We can have a provisional here with a cantilever onto this side. So we don't have to worry about a denture or a Essex retainer, and we don't have to worry about placing the implant. We can stage this approach. This is a photo contraster I'm using. So this is a black background. These are really nice to have. They're about $50 or $60. It's a photo contraster, allows you to see the shade really well and masks everything else out. So after 4 months, for this, we're building the buccal plate back up again. So I like to wait about 4 months for this. So after 4 months, we have good soft tissue profile. And we have nice bone here. We have 7 millimeters of ridge width, and we have about 13 millimeters of length. So that's a good area to place our implant. We have a nice wide ridge, as we can see here, and good soft tissue. When we did our extraction, we preserved that soft tissue, and with our extraction, we allowed the keratinized tissue to granulate in by secondary intention over the top of the ridge. So you want to avoid taking that flap and moving it all the way over the top of the ridge for primary closure, because we get to have so much more for the secondary intention. If we measure another part of our bone here, we have about 9 millimeters of ridge in this area. So we're looking good. When we go to our implant surgery, we can see where the buccal plate was lost. This is called a papilla-sparing incision. Papilla-sparing incision allows us to maintain the soft tissue on our adjacent teeth. And then we can do our implant surgery in this grafted bone, which is now her own bone. And that's the benefit of the allograft materials. It turns into their own bone after about 3 months. We can have our implant surgery. We're in good position in this area. We want to be a little bit below our osseous crest, and we can graft this area. So you don't want to place your implant too deep. You want to be about 2 to 3 millimeters from the adjacent to CEJ. And then we can graft and build this back up again. So we're going to add more bone graft. For those of you who are coding at home, when we did the extraction and bone graft, the code for extraction and bone graft is D7953. Then the code for implant bone graft at the time of implant placement is D6104. And you really should code those if you're going to do bone grafting at the time afterwards. You can decide what you want to charge for those procedures, but you are doing another graft many times at the implant surgical phase. We can place our bone graft material. This is amnion chorion membrane. This made from amniotic tissue. It's very thin and very bio-friendly. And we can see we can augment that tissue even more. This is one of the products from Salvin. There's other companies that make this as well. And then we have we can do a 3D scan. We use a Trios for this. We're doing this so we can make a provisional restoration for the patient. We can make a provisional restoration so that at the time that she comes back for the checkup, she lived about an hour away. So the time she comes back for the checkup, we can have a provisional implant crown ready. So if you're not ready to make chairside provisional restorations, then you can have the lab make these. We take an impression and we have a chairside provisional. The benefit of this is we're going to be able to develop our soft tissue profile. It's critical with our anterior aesthetic makeup. So this is our screw retained provisional restoration. The patient can go home. She can wear this provisional restoration. This is after our implant's been placed and after 3 months of integration time. So this is where it's a staged approach. This is not immediate. We want to see how the soft tissue responds to a restoration. So we can have her wear this for a month or 2 and longer if we need to. So with our provisional restoration here, we've built up our keratinized tissue, we built up our hard tissue, and we have a screw retained provisional, and this is made by the lab. 2 months after wearing the provisional, we have a really nice soft tissue profile. We have a great soft tissue profile that we can use and utilize for our final restoration. Next thing we have to do is how do we relate this provisional restoration to the lab? How do we say make this provisional just like we did our final restoration? We can do this with kind of an analog technique with custom impression and PBS material. And we can also do this digitally. So we have a really nice profile here developed by our soft tissue profile. Our standard impression posts, whether they're digital or analog, are going to be more circular in nature. So we want to be able to pick up and capture all these areas. We can use some composite. This is flowable composite. We can also use some packable composite to pick this up so that we can do a PBS impression for the lab. And I'll show you how to do digital as well. This is a different case, but this is how Dr. Goodman reacted. He said, wow, you really unscrew those fast. So this is at about 3 times speed to be able to show everything. But we take out the provisional restoration. This is a little hemodent. Hemodent's nice because it allows us to maintain our soft tissue profile for longer. This is a PBS impression post, and you can see how much we're lacking in these areas. So you can put a little bonding agent on there. And then as we're developing in here, Let me see if I can. We have our poll up here. How many implants do you place a month? It's really good to know. And let me see if I can. So then we have our provisional restoration, and we can come here. This is placing our composite. You can place your composite, kind of like a facial composite. And then we can build up our soft tissue. And we're going to support our soft tissue so we can take an impression. We can do light body and heavy body impression and capture that material so that we can have a customized impression post. From our patient, many times in the anterior, to place the implant in an ideal position, sometimes the implant may have to be angled a little bit towards the facial aspect. We have something with angled screw channels, which are awesome. Angled screw channels can move our screw axis up to 25 degrees and maybe even more at this point. So if the angle of our implant is coming out towards the facial, we can have an angled screw channel, which allows us to have our access point for screw retained restorations more towards the lingual aspect rather than coming out the facial. So rather than having a big hole in the middle of the crown, we're doing an angled screw channel. So really encourage you to talk to your labs about angled screw channel. So we can have an angled screw channel with our access point on the lingual aspect, and we can keep this in good shape. We have our soft tissue profile, and we can deliver our final abutment and crown, maintaining our soft tissue profile, and developing a nice smile. And we can do our final abutment and crown for our patient. So we went from heart tissue defect. We had a lack of bone in between here. We had buccal plate loss. We built this up with a staged approach and developed a nice contour for our patient. Next, we're going to go into some extraction techniques. You really want to do HMAC extractions. This is a curette with some serrated teeth on it to clean out any infection or any palatal tissue or PDL tissue. These are deep grip forceps. These are PDL elevators. These are from Salvin. These are a really nice kit. They're very narrow, but much more rigid than your old-timey PDL elevator. These really get down. They're very narrow. I use these for anteriors. And I use these Tatum elevators for most of my molars, including wisdom teeth. These are very narrow and work very well. And once again, I don't have any financial interest, but these are things that I use in practice. Talked about our allograft procedures. And this next question is, how many implant overdentures do we do a year? Implant overdentures are such a great tool for our patients. And we also have our membranes. We'll talk about our membranes like we did before. This is our resorbable membranes, which are really my workhorse. We can also use PRF. PRF has been widely discussed. And what PRF is, you take autologous blood, so your patient's full blood. We have a centrifuge to spin this down, and we can isolate platelet-rich fibrin, a membrane, and also a platelet-rich fibrin liquid. This is a video that we have for
how you doing? I'm Dr. Matt.
blood draw at our office. This is Diana. And this is one of the courses that we run. If you go to our AAID annual meeting, we're going to have an awesome seminar with Dr. Rakowski and Dr. Ganaden about PRF, blood draw. So if you want to do this hands-on, come to our AAID meeting or another meeting, but AAID, we have great training for our blood draws. And we can get our blood draw. We have our tourniquet set up. We have our butterfly needle. I'm squeezing my hand. We have some good blood flow here. This is our ability to develop our autologous blood. So that's all of our autologous blood. We're going to place this in a centrifuge. And then from that, we can develop PRF liquid. This is platelet poor plasma, platelet rich plasma, and red blood cells. So we can isolate this platelet rich plasma, and we can use this in our bone grafts. We also have platelet rich fibrin we can take from here. Platelet rich fibrin, we spin down the autologous blood, and this is with without the anticoagulant in there. So this coagulates, and this has PRF, platelet-rich fibrin, we can use for wisdom teeth, we can use for membranes and grafting. So there's a lot of cool uses that we have for this. So after we spin down our blood,
that is looking good. This patient is really good
plasma.
That's me.
So we can take this, and we have our nice platelet-rich fibrin. We can compress that. We can use it for our grafts and sticky bone, a lot of good things. So in our AAID meeting, you can take a hands-on course with this. So this is an immediate implant surgery. We're going to do an immediate implant surgery and immediate provisional. This patient had a bicycle accident. He fractured his number 8 central incisor below the osseous crest, so we've deemed it to be non-restorable. The clinical crown comes off very easily. One of the things for our extraction techniques is you want to preserve that buccal plate. You know, how do I grab it? How do I grab down here? There's nothing to grab. So we want to preserve this buccal plate. We can elevate with those thin PDL elevators, but we can also section the tooth, so we can break it up into pieces. So we can section the tooth here, and a lot of times I'll try to take out the palatal first. Once I take out the palatal root, then I can take the buccal section and move that towards the palatal aspect. So we can preserve that buccal plate. So we can take out our palatal, our section here, and we can elevate, preserving that bone. And then we have the rest of our tooth here. We can make a little trough here and elevate coming to the side. So what we wind up with is a socket that's preserved. And now we have a type 1 buccal plate that we can use to place that implant. So we preserve that soft tissue, atraumatic. I did a sulcular incision around here. And the next thing we have is, this is our palatal aspect that we mentioned. We have our palatal aspect and our buccal portion. So as we look at the pure socket here, this is our buccal aspect here. This is our root tip, or apex of our root. The drill is going to want to go towards the apex of the root. We want to redirect it more towards the palatal aspect. If we go right towards the apex, we're going to wind up going out through the buccal plate. So we're redirecting this more towards the palatal aspect. And then we can start to go through our drilling protocol. And I do have a video that we can show you on immediate. We have our implant placed in the area. We want to leave at least 2 millimeters. We have about 3 to 4 millimeters here. We want to leave about at least 2 millimeters in between where our implant platform is and our buccal plate. Reason is, if we get too close to our buccal plate area, we're going to wind up with resorption of our hard tissue and soft tissue. And after a couple of years, we're going to wind up with a lack of bone regeneration. So we can place our implant more towards the palatal aspect. We can bone graft around here. For him, his whole tooth was in good shape. So I was actually able to use his tooth as a provisional. But you definitely don't have to. We have tons of polycarboxylate crowns that you can reline and use chairside. If you can take an impression, you can make a provisional restoration, or if you have a couple days, you can have the lab make you a provisional restoration, like I showed you in the other case. This is a temporary abutment. We hollow out his tooth, and then we can reline this. We can reline this chair side with some composite restoration. So we trim down our abutment, and then we can reline the tooth with some composite. When we first take our clinical crown out, this looks a little irregular here. We have the tooth over the top, and we want to attach this to our abutment. We can take this out of the mouth, and then we want to contour these areas. We want to make these contour concave. Concave, so our soft tissue grows back in the area. We can also make them convex later on if we need to. And then we have our soft tissue. This is a concave profile. And then we're going to make this tooth a little bit shorter than the other tooth. And we tell them that before we start, that the tooth is going to be shorter because we don't want them to bite in or clench and grind while they're going through function. If they're not okay with the tooth being a little shorter, then a flipper is a good restoration. They can also use an Esthetic retainer that we make for them. This is a little bit of the composite where we added on to it. And we have this after about 4 months healing, so you can see what 4 months looks like. You can easily polish that up and redo that if it's an aesthetic issue. But the key is we're able to develop a really nice soft tissue profile here. A soft tissue profile we can capture and send to the lab. We're going to send this to the lab digitally. So we've developed this nice soft tissue profile with our photo contraster. We have an impression post. This is a digital impression post. So we want to scan the temporary. We want to scan our soft tissue profile and also scan where our implant is. So I use a Trio system. There's other systems as well, Medit and iTero. I do like the Trios. What we have on our landing page is we can scan our emergence profile. We can also scan our pre-preparation, which is the tooth, and we can scan the actual impression post. So our first scan is of the temporary tooth, and then we scan the emergence profile. So I don't have to build up that impression coping like I did with the analog technique. We can actually scan the emergence profile, which is so important. Once we scan the impression profile, now we can add in our impression post and we can scan that. So we can develop all of these together. And the lab can see exactly where our profile is, exactly where our impression post is. We can overlay our provisional restoration if we want them to duplicate it, so that we can develop a nice contour and relate that information to the lab. It's so much better than the analog technique. But if you don't have digital, you should invest in it. It's definitely going to help. But if you don't, then you can use that other technique I showed you. We can do a 3D printed model, and we can use that angled screw channel again, so we get the most amount of ceramic present. These angled screw channel, we have a different type of tool, which is more narrow, which allows us to change the contour from our screw. This is facing more buckle, and we can move this all the way to the pallet, so you can see how much that can be moved. And we get to our final restoration. And the immediates are nice because we preserve the hard tissue and preserve the soft tissue. So we're just keeping everything that the patient has rather than having to rebuild. And that's with that type 1 buccal plate. So we're maintaining what the patient has, maintaining the gum tissue. So there's less rebuilding and having to regrow tissue. We're maintaining what they have. And these are x-rays. This is a 2021 when we delivered, 2020 when we placed during COVID. And this is a 4-year follow-up. So we've been able to maintain this well over the years. And with our surgical x-ray, with the provisional to our initial healing in 2021, our bone levels maintain and stay the same. This is an implant that's textured all the way up to the top so that we can have bone growing here. And some of our areas are subosseous. We're still going to have good bone preservation. So we'll talk about some guided also. We'll talk about some guided surgery. This is a patient with atrophic ridge. We took him through some orthodontics first. He had some trauma. This is the end of our, we did clear correct for him. This is the end of our clear correct. We can do our digital scans. And then we can also do our CT scan. We can do our CT scan. We can see we have about 7 millimeters of bone. It's pretty good for a 3.5 millimeter implant. 4 millimeter implant maybe, but 3.5 to 4 should be good here. This is our guided surgery. So we have our trio scans, and then we do our CT scan. We do our CT scan. Patients' teeth have to be open, so that we can register the CT scan occlusal surfaces with our digital intraoral scan that we use for the trio. So you can use a bite stick. We have those little cotton applicators they can bite down on. The further you put it back in the mouth, the more it's going to open in the anterior. So try to get at least the premolar area. We also want to use some cotton. If one of these, the Buffalo Bills, I'm going to check this one. Buffalo Bills are definitely going to win the Super Bowl in 2026. Eagles are going to be tired after that Super Bowl. They scored too many points. So I'm taking my Buffalo Bills. I was actually just in Buffalo this past weekend visiting my parents, and they had a lot of Bills gear out. So I bought some Bills gear for myself and for my daughter, Lily. The son Joseph also, but he's definitely more of the 49ers fan, and 49ers are number 2 for me. The Bills are definitely number 1. But I got home and I told my father, I said, I bought all this gear. I said, I think that the Bills didn't win the Super Bowl for the last 50 years because I have not bought new gear 2 weeks before the season starts. So I bought new gear 2 weeks before the season starts. So I checked off that box. The Bills have to win this year. All right. And I did live in Philadelphia for 7 years, but Philadelphia fans never embraced me. Bills fans, absolutely. 49ers fans, definitely. All right, so we have our cotton rolls. The reason for that is we want to obscure where the lip comes in, so we can see exactly our soft tissue profiles. I'll say some things about guided surgery in general. We obviously can't cover everything for guided surgery in this course, but I want to leave you guys with this. I did a surgically based residency program at Albert Einstein. I was really into implant surgery. I got into private practice. I took a AAID maxi course. I was placing more implants, but there was implants I still was referring out. I had a very specific patient, which was really a game changer for me as far as my mentality. It was 3 implants in the posterior mandible. Felt, you have inferior alveolar nerve, bony concavities. So I want to refer that out for the surgery, and I want to do the final restoration. I set the patient out for the scans. I do have a CT scan in the office. At the time we set the patient out, I developed a surgical guide. I did all the planning, had all the tools, everything. Patient was in our office. The patient practice I was at in New Jersey. Patient really wanted me to get her numb. So I went over, I got her numb. And I went back to my patient. It was number 31, class 2 composite. I remember this very well. Prepped the composite. I'm starting to get my bitine ring on. There's moisture coming through. Can't do rubber dam in that area for where this was. I have finished it. Realized I didn't get enough tight enough contact. Had to drill some of the composite out. Put another bitine ring in. I'm struggling with this. It took me like 45 minutes. And the surgeon came in with the Panorex and he's like, hey, that surgical guide worked really well. The implants went in just like you planned it. I was like, I need to do this. I need to ramp up my implant career right now. That was the game point. And it was good because I planned the whole case. I had good surgical skills and I was really on top of, the guided surgery. If I just said, oh, this case is too complicated for me, I'll send it to this guy or this woman and they'll place the implants and I'll restore it or may not restore it, you won't get that experience. So even if you're referring out and you want to do implant surgery, it's good to go through this planning. So it's been a game changer for me. So guided surgery, we can see where our bone is. We can plan where our implant is. We can get a nice surgical guide protocol set up. From this, we can develop a provisional restoration based on our guide. We have our surgical guide in place here. And we have a provisional restoration. I like to make these non-engaging. That allows us to have a little bit of flex when we have our provisional restoration important, so we don't have to engage all of the internal component. If you're making these out of plastic temporary abutments, then you can quickly remove the internal component. And if you have an internal component here and the orientation is slightly off, you can adjust off the internal hex part of it. But this we have non-engaging and we have an angled screw channel. I'll show you a video of this. We can do a papilla-sparing incision like I showed you earlier to preserve that soft tissue rather than just drilling through, because we do want to preserve this tissue, especially in the aesthetic zone. If we're drilling right through tissue, we're going to have very thin papilla, very thin soft tissue. So with guided surgery, we can place these through with our surgical guide. And we have a menu, a prescription. We have our surgical guide in place for one unit or multiple units. And we're basically going down to the flat part of our drill here. And then we're engaging that to depth. So it allows us to very effectively go through and plan our cases. There's many different types of guided surgery systems. You can use one that go directly into the guide. You can use one that has a key that holds in there, and both are fine. One of the benefits of this is you can place the implant through the guide, which is nice. But I will say it's not the most important thing. And many times, even if I have the ability to place the implant through the guide, I don't. I like to take the guide off and see where the implant's going, see where the bone is before I insert it. So this is some of this guided surgery case. We can have our position. We want to preserve that soft tissue. We do our trio scan. We have our scan of the bone. We merge those together to develop this model where we have our teeth in place here and we have our bone in place here. So we're able to merge those with our software. We have our surgical guide, and we can do our incision. Try our guide in. If you're not sure about guides, maybe this is the first time you're doing it, you can always bring the patient in, try the guide in. I so recommend that. Bring the patient in, try the guide in, make sure it fits. If it's in the posterior mandible, make sure you can get access and get all the way back there. Make sure you have the right tools, the right drills, do a whole test run. Make sure you have everything before the patient comes in that day. So doing that beforehand is good. You make sure you know your systems. Make sure your team knows the systems. Let the patient know that you're going to try in and verify before you schedule your hour or 2 hours for the implant surgery. So we can go through our guided surgical technique. This is decorticating the top part of the bone. And now this is a drill that's expanding the size of our osteotomy. So we can do these procedures well with a predictable manner. These are nice also where we can see the bone. You want them to make the guide so you can see as much bone as possible. We have a top part that goes on top of our implant. This is the driver mount for the guided surgery. And with this one, we can place the implant through the surgical guide. And that's placing it with the implant handpiece. And then we can also torque in by hand. Next, we take off the surgical guide and we have the implant placed through the guide. With this system, you want to make sure that hex is even here. So we want to rotate that a little bit more. With our plan, we have enough bone around the implant. You want at least 1.5 millimeters of bone around the implant on the buccal, and at least 1 millimeter on the lingual. We have our screw retained provisional restoration here that's non-engaging. This is where it's concave at the gingival margin. You can add to these if you want to. We can do our suturing. Can suture with an apically repositioned manner, so our soft tissue stays within our tissue. We have our suturing here. And once again, we're a little bit shorter here. And we want this to be concave, so more soft tissue grows over. We can have him smile. This is after 2 weeks of healing. We do our suture removal. You can still see where the suture lines are a little bit. And we have a little bit uneven soft tissue architecture right now. And we're going to let this heal, and then we can always develop this later. This is after 3 months of healing. And we have a lot of good soft tissue. You can see where our soft tissue profile is because I under contoured or made the healing abutment concave. So now I can take off my screw retained provisional restoration and I can add on to here. So I'm making this more convex now. Making this more convex, I can impact our soft tissue profile. I can have the patient wear this for a couple weeks or a month, and we can come back and we can do our digital impression. From this now, I'm really happy with my soft tissue profile. So I scan my temporary crown with our soft tissue profile. I scan our emergence profile, and I also scan our impression post. So we're able to do all this with our digital scan, and the lab can now seamlessly go through and develop our final restoration. And with our scan body. So we can develop our final crown. It's a 3D printed model. We have a verification jig that I love to use. This allows us to put the crown in properly all the way, but also when we're torquing in our screw retained crown, this supports it on either side. So it serves a couple purposes. This is that angled screw channel again. We can make a really nice provisional final restoration. Provisional restoration and final restoration, screw retained, and our soft tissue profile that we developed both surgically, but also with the prototype. As we go through, it's really important to understand bone expansion if you're getting into implant dentistry. And there's different types of bone expansion we can do. We can do bone grafts. We can do block grafts, we can do particulate grafts, but we can also take the patient's own bone and move it into a better location. We can do this with burrs. These are densa burrs. These will spin in reverse. We can do this with piezo surgery, and we can also do this with ridge expansion osteotomes. I use all of these, and I really encourage you to learn how these work, because rather than drilling bone away, we can augment bone with our drilling techniques. So this is our osteodensification burr. If we drill forward, we cut bone away, we remove bone. If we spin this in reverse, we can densify the bone, and we can also expand bone out vertically and horizontally. These cases I showed you in the anterior, a lot of times we have 3, 4, 6, 7 millimeters of bone. We don't have 12 millimeters of bone. So rather than drilling that bone away, you want to do everything you can to maintain that bone. We can use osteotomes. Osteotomes are hand instruments, and we have these contours here, which allow us to expand the size of our osteotomy. This is a more narrow one and becomes a more wider one. So this is our osteotome technique. We did this in conjunction with a guided surgery case. This is a keyed system. So we do a pilot drill here, and then we have an osteotome. So rather than drilling out all that bone, I want to preserve that bone for our implant. So this osteotome is widening the osteotomy by hand by placing this in here. We have a narrow one we use with the pilot drill, and then we have wider ones as we go through. So rather than drilling away 2 or 3 millimeters of bone, we're expanding it and moving it to a better location. And that is much better bone than doing a block graft, than doing a particulate graft, because it's the patient's own bone in a better position. We can also use the piezo for ridge split procedures. This is a patient who has an atrophic ridge, and we want to expand that ridge and then place the implant. We have good soft tissue here, which is always important, having good soft tissue profile. And this is a piezo surgery. So the piezo, we're doing what's called a ridge split procedure. So the ridge split procedure will allow us to expand this bone with moving the bone onto a better, more buccal position rather than drilling it away. And we can do this many times without block grafts and without, well, we still use particulate grafts. So I'll show you here, we're still going to use a particulate graft, but we can do this at the same time with augmenting. A ridge split like this is not going to increase height of bone. We're increasing width. And you can see right now we're increasing this width in the area with this piezo technique. It's a lot of fun. It's a lot of fun to use. And now we're expanding that bone out. And we expand this out, and we're making this osteotomy by expanding the ridge. And so we're not taking bone away, we're expanding it. Now this is the osteodensification burrs that spin in reverse. So we've already expanded this bone out a couple millimeters before we're even doing any drill. So I'm using this drill, but you can see it's not hitting bone. I'm just drilling apically so that I can start my osteotomy. So I'm drilling forward here. And now I'm going to spin in reverse. So I'm spinning in reverse and I'm expanding this bone out to enhance that bone in the area. Like we showed on the other guided case, if you have enough bone, that's great. But many times we don't have enough bone, or we want to move the bone to a better position. So we can see how we're expanding this bone out with these reverse cutting drills with osteodensification. And then we can go to our final drill. I will say you don't want to expand your bone so much that you lose blood supply. So many times after I go through expansion, I'll take my last burr with the company that I'm placing and roughen up the inside surface of the osteotomy so we get good healthy bleeding. You can also take a round burr and get some healthy bleeding going in. But if you've osteodensified and expanded so much there's no bleeding inside your socket, you're not going to have bone to implant contact. So you want to make sure that you give yourself some opportunity to use a final drill to roughen up the inside surface. This is a round burr. I'm decorticating with a round burr. And this is the PRF liquid for some bone graft factors. This is our allograft, which is hydrated with the PRF liquid. And for this patient, we also use the PRF membrane, which is really nice. The PRF membrane will give us good hard tissue stabilization, great soft tissue. It's going to thicken up our soft tissue as the body heals, and nice for this area. You can bury this if you want to. We did this single stage, but you can bury this and do an uncovery afterwards. We can take the rest of our PRF liquid and get some good growth factors. We get to our final abutment and crown. We have good soft tissue profile, good hard tissue profile, and we've augmented that buccal aspect. So some pretty cool things you can do. And we're able to place that implant in a good position and finish with our soft tissue profile. This patient has more bone, about 5 millimeters of bone. And if you're getting started with the piezo, you can start in an area where you have a lot of bone. So I have a lot of bone here, and I'm using it more to densify. But this is a good area to get used to the piezo rather than that first case I showed you where it's very, very narrow. But the piezo is very relaxing. Right now we're compressing the bone, we're expanding the bone, we're taking the bone from type 3 bone and type 4 bone into nice compressed bone. So we can do that for our patients. This is she has congenially missing lateral. We have a ridge defect. We can do our ridge split, and we can do our osteodensification. So I will say, you have these burrs. These burrs probably cost about $1,000 to $1,200. Piezo can cost anywhere from $5,000 to $15,000, depending if you have an implant console on top. Those osteotomes are usually about $1,000 for a kit. I like all of them, but I really think that the osteodensification burrs, if you're going to get started with things, the osteodensification burrs are probably the most useful, very cost effective, and you should definitely incorporate them into your practice if you're doing any implant surgery. You need to densify the bone, and you need to move the bone into better locations. Which of the procedures frustrate you the most? Class 2s, absolutely. I have a great team at the office, and they do great work with the bitine rings and beautiful. And for me, it's the class 2s. And then we can go through our implant surgery. We can do our bone graft again, build it up, and develop our scan. This is a nice trio scan. So for our digital aesthetic planning, we can also plan these cases digitally. We have our teeth here, really close to the buccal plate. We have tons of bone to the lingual aspect. So we are going to do this a free-handed surgery. And 3D planning, we want our implant in this position here. We can use these osteodensification burrs to spin in reverse. We do our atraumatic surgery. I'm going to show you a video of this. So we can do a nice cellular incision. We can section off our bridge. You really want to be careful you don't break the teeth in the buccal plate, so section that bridge carefully. We can use the piezo surgery with the periotome, and we can use this to loosen up the periodontal ligament. But if you don't have a piezo surgery, you can still do this very atraumatically. So this goes around and loosens up our periodontal ligament. These are the Salvin PDL elevators. This is a bayonet. It's really narrow, but it's very dense, and you can get some great movement with the teeth this way. We're elevating towards the palate. You don't want to elevate towards the buccal plate. So we can elevate these through. These are the PDL elevators. I spent a lot of time elevating. These are very narrow. We're taking out front teeth. These are straight forceps, and you want to rotate circular in a mesial and distal position. You don't want to rotate buccal and lingual for the front tooth. With our lateral incisors, you have to rotate a little buccal to lingual. But before I take these teeth out, they're already very loose from my piezo surgery and from my PDL elevators. This is our immediate technique. And we're placing this more towards the palatal aspect. More towards the palatal aspect to develop that nice contour. As we go through, these are the osteodensification burrs. They spin really nice. And now we're expanding the bone and compressing the bone in this anterior maxilla by spinning in reverse rather than drilling bone away. You can take these burrs and drill forward with them also. And this is what I was talking about. This is my final burr I'm going to use, my final drill sequence. It's smaller than the implant. You want to undersize these. You want to save all that bone that's on the end of the drill, use that in your bone graft. And we can go through our drilling sequence. We can place our implant. We want to get good initial stability. If I'm going to immediately load, you want to have at least 35 to 50 Newton centimeters of insertion torque. So right now we're at 35 there. And we can insert the rest by hand and place our implants. So we have our apex. This is where our osteotomy is going to start, lingual towards it. We have about 2 millimeters before the buccal plate. You can reline our provisional restoration. Make the teeth smaller. And after 4 months, we have great soft tissue profile. It's our great patient, Dennis.
Today we have one of our favorite patients here of all time. You can see he's blushing.
Yeah.
One of our awesome patients.
And I haven't been paid to do this either. So.
No, you pay us.
Oh.
If you can believe that. Even better. Right?
Like an Amazon promotion.
Yeah. Well, you're one of our favorite patients of all time. We appreciate your seeing you and everything that you bring to the office is so much fun. Beautiful photos you do for us is amazing. Yeah. We've gone through some implants on the lower a couple years ago. Now we've gone through some implants on the upper. Why don't you tell us about the upper implants?
The upper implants have been great. The original bridge was in there about 35 years, and it just finally gave out. This temporary has been really comfortable. Absolutely no problems after procedure. No pain, no swelling, I didn't even know I had it. So
that's awesome.
This has been great, and I can't wait to get the permanent ones. The temporary ones look great.
They do.
Matter of fact, for the longest time, I thought this was the permanent.
Yeah. Well, we had a great model to work with.
Yeah. Well.
And tell us about that implant surgery. We took out the teeth and put the implants in and put the bridge in at the same time. So immediate implant therapy.
And I had no pain. I had no soreness. I went home and I've had absolutely no problems whatsoever with them.
That's awesome. Well, things are looking really good. We're ready for our next phase where we're going to do digital impressions. Do digital impressions of the implants to make the final teeth, and we'll duplicate what we've done with the temporary so far.
That's great.
We have our great team over here. We have Nick and Karen are going to do our scans, and both of them.
Give a shout out to Nick. Nick's graduated from University of Buffalo Dental School now. So Nick's doing a residency in Buffalo. So Nick's done a lot with us over the years. We're very, very impressed by him, proud of him, and excited for his future. So, one of the key things that the dentist said was, they look great, pain-free, and they felt awesome. And, Paul put up there, what's your least favorite procedure? The class 2 composites. I've done facial composites and class 2 composites. I've gone through all the proper techniques and very minimal preparations, and the patient can still have sensitivity, months later. They're like, I drank something cold last weekend and I felt a shooting pain through my tooth. Implants are great like that. You can do these procedures and patients feel awesome afterwards. So we can do our digital impressions. That's Nick again. And we can do our digital scans. This is our GUI impression over here. If you are still doing GUI impressions, you have to get digital. The fit is so great, it's so precise, it's going to save you money. All this GUI impression costs money. The Trios will pay for itself over time. We're able to go through these scans very quickly and efficiently. You can do a scan in less than a minute. We have our staff, when they do training, they have to be able to do a scan in under a minute. This is during COVID. We still had masks on. So now we do our upper scan. It's very hard to train an assistant who has no experience on how to do an alginate. And then they finally learn how to do an alginate. You tell them to pour up the model. They pour up the model. You check it the next day. There's voids everywhere. And so that alginate is useless. It's very difficult, much more harder than I ever thought it would be. But the newer assistants who are coming through, they love this digital technology. They can do the scans. We just scanned our provisional. They can pick this up fast. We're going to scan this particular one. We're doing an encode abutment. You can also do a scan body. We're scanning the impression. We're developing all this on our screen. This is the best part for me is the virtual bite. Look at this virtual bite. It takes like 5 seconds to do a bite. With the gooey impression material, they bite down, they shift their jaw, everything's off. You're like, oh, you opened up too fast. Like, what do you mean I opened up too fast? Got to do it all over again. You got to pick all this material out of the patient. These digital scans are just biting down on air. I mean, it's so accurate, so precise. So get digital, get digital, get digital technology, invest in it. It's going to be awesome. So we scanned our teeth. We scanned our emergence profile. We have our abutments. We can develop our final restoration. This is a screw retain restoration with digital. You can keep a lot of this internal hex. So we avoid screw loosening and non-engaging implants. We can develop our prosthesis. We preserved our bone, preserved our hard tissue. And Dennis is going to be in great shape here. And this is our drilling protocol from that more towards the lingual aspect. And we're going towards that lingual aspect. So I think, we have a good, this is a Tahoe. If you guys are looking for something to do, ski in Tahoe. It's been
Matt,
a great.
I might have, it might be
family.
me. Can you see me?
Yeah.
I think we lost it. Are you trying to show a picture? I think I lost it, unless it's just me.
Let me bring that back up here. All right. Can you see now?
Yep, I can see now. Like I see skiing. I do sitting, but skiing sounds fun to some people.
Yeah. Beautiful Tahoe. This is heavenly. This is our main spot to go to in Tahoe for skiing. A lot to do. A lot to do in California. This is redwood forest. If you have the opportunity in California to get to the redwood forest, these trees are 250 years old. These are breathtaking. My wife and family, Joseph and Lily and Soki, we were in the redwood forest. I said, wow, these are so beautiful. And the kids were like, this is so beautiful. We look around here, and basically there's the adult tree, the parent tree, which is in the middle. During a forest fire, it germinates the pine cones, and it develops all these sibling trees all the way around it. And that's how they survive, is by forest fires. For me, I was standing in here, and I said, wow, this looks just like a full arch implant case.
Yeah.
Look at all these perfectly aligned systems.
Yeah.
It's been going on for hundreds of years. So let's just embrace this. So
Love that, Matt. Matt, if we can, we're gonna do a few speed round questions if you don't mind, and then we'll get to the thing. So speed round questions mean try to answer them, and bring up your contact slide one more time, just in case people want to kind of leave that up there for now. Perfect. How do you know if you've expanded too much and lost blood flow? Does that make sense?
Yeah, it's a really good question. You almost have to do it to understand it, but basically blood is good. And when you take out a tooth or you drill an osteotomy, and there should be bleeding. Good healthy bleeding, not so much like a patient who's on the blood thinners, but good healthy bleeding. As you start to expand bone, you're taking that bone, you're densifying it. If you have type 4 bone, it's very, very loose bone, and you're compressing it more into type 2 bone, which is great. But there still should be some locular areas for the bone. Once you compress too hard, you actually see a ring all the way around, and it's just like a bone colored ring with no bleeding. And that's definitely expanded too much. You don't want to do that. You want to avoid it and do a little less next time. But if that does happen, you really want to give yourself an opportunity to have a wider drill. Use that wider drill and drill that area out so you get some good healthy bleeding. Even after the osteodensification, I'll take a round burr sometimes and decorticate, not the buccal plate, but on the palatal and mesial distal to get some more healthy bleeding going in there.
Awesome. Great answer. Great question. A question was, how do you scan the emergence profile? That was from earlier, but I'm not sure if that's, how do you scan the emergence profile?
Yeah, the emergence profile is, let's see here. The emergence profile is scanned at the same time you're scanning let me go back here. So once we're at this phase here where we're scanning, we scan the provisional restoration. Before we take off the provisionals or anything, we do a scan. We scan the whole upper and lower jaws. Then we go to the next screen on Trios, and we do emergence profile scan. For this, we take off the provisional bridge, and then we just scan the area of the provisional, where the provisional bridge was, where the actual emergence profile is. And then we put our scan bodies in and go to the next screen and scan the scan bodies. So it's very, very simple. Let me see if I have that within here. Are you still able to see this?
Yeah.
Nick to do our digital scan on the low.
So as we're coming through here, his teeth is so right now we have our
To get all that soft tissue
preparation
contour that we've
emergence
developed
profile.
with our provisional restoration.
So we're scanning his upper teeth first. We can do that before we do anything else, scanning the provisional. And his provisional is up on the screen there.
Yeah, all 3 daughters are.
Now we take off the provisional. And I guess I don't show that part, but our scan body is here, but on this other one, we don't have the scan body in. So before we put the scan body in, we would do another scan of that emergence profile. It's going to look very similar to what I'm doing here, where I'm scanning the scan bodies, but I'm just scanning the scan bodies. So the rest of this impression is still all intact, and I'm just rescanning over this one area.
Thanks for clarifying that. I really appreciate it. Bring up your contact info one more time. If you didn't get your question answered, I know there's about temporary abutments and zirconia crowns. My friend from New Jersey, I'll ask these in New Jersey, and why use a non-engaging temporary abutment?
For a single unit, it gives you a little bit more flexibility at the time of surgery. You can move that a little bit. If your hex is already in one position, you don't want to rotate it at all. Non-engaging is also very useful for full arch cases. Full arch cases where many times we use non-engaging because the implants, they might have some degree of divergence to it. So non-engaging allows us to get a whole platform. So maybe we'll get another webinar going, Paul, with engaging and non-engaging. I think that'd be part 2.
Yeah, that's Rocky too. I like that.
Yeah.
I want to have my team, if you guys could just bring up the presentation for me 1 second, Lindsay, because I think I need, unless I use your little tip here. Oh, wait, I think I got it. Hold on. I use Lindsay's tip. What we're going to do is going to give you the CE code, or how to get the CE code here. And let me see if I can do it myself here. I think I can. I did it. Good. Get the CE code here by texting code to this number. This concludes our awesome CE, but we're going to hang around for a few more minutes, ask you guys a few questions. We have so many people watching in, which is awesome, on Nachos CNTV. So Matt, I'm going to launch a poll here that asks if you will be attending the AAID conference. So some people might have missed in the beginning. What are some of the benefits? Some people are thinking about it. Some people would love info. They've been very inspired by your ability to unscrew an implant abutment quickly and also deliver value. So tell us a little about this AID conference.
Yeah, it's going to be a great conference. You know, the main podium shows state-of-the-art techniques, surgical and restorations, digital dentistry, guided surgery, bone grafting. One of the great benefits of these meetings are hands-on. The hands-on program, we have programs on PRF where you can do venipuncture and blood draws. We have hands-on for suturing. We have a hands-on cadaver program. You can do implant surgery on cadavers. We have suturing techniques, guided surgery. You get to see companies. You can go and play with their tools before you purchase them. Talk to experts. And make friends who are in implant dentistry, and you might already have some friends there that you didn't know were going, or bring some friends with you. It's always the most fun to go through this this journey of dentistry and implant dentistry with friends and colleagues. They're the ones who help to keep you on track and help you keep going.
I love
And
that. Now, my next question, Matt, is the AID membership, which is 24/7, 365. We have people saying they'd like more info. Are there discounts for new dentists? You are the president. The AID membership, we're going to send people who are asking information. There's four people here who are already members. What's some of the value of being an AID member outside of the main symposium?
yeah, membership is great. Just for learning, we have our Implant Institute, which is online training and online education. Paul and I did a talk about that, where you can access it 24 hours a day, 365 days a year. That's all part of your membership. There's CE in there. There's programs you can learn about different techniques. We also have membership to the Journal of Oral Implantology. That's our implant journal, which talks about latest research and techniques. Many people also do Maxi courses. There's Maxi courses, about 15 throughout the country. Maxi courses are 300-hour courses that you can go and somewhere in your region learn more about implant dentistry, develop colleagues. And one of the greatest things is credentialing. We have a very bona fide credentialing process for implant dentistry with our AAID fellow and through the ABOI diplomat. So you can be credentialed, raise the level of your practice, and really help the care of your patients. And yeah, a lot of good things for membership. You asked about for new dentists. We have student memberships, which is very inexpensive, and then we also have new dentist memberships, which are less expensive. So you'll have the benefit for both of those, both for student and for new dentists. So you get to click the level that you're at.
Awesome, Matt. What I've known for asking at the last question to anybody when I have them on a webinar or podcast is just, we have this poll here showing that we have, I'm so impressed. People stop their day. Some of us noon in the East Coast, some of us, what do you guys, you're not in the future, you're behind us, 9 a.m. out there on the West Coast. Practice owners, associates, dental students, people who love helping dentists. What do you wish you did sooner in your career? Who do you wish you connected with sooner? What service do you wish you did? If you go back in time and do something sooner, Matt, what do you wish you did sooner? It can be on any topic related to ownership, work-life balance, staying sane.
Well, it's a journey. You go back, you say, "Oh, I wish I would have done this or I would have done that." But all those things have gotten me to where I am now. I've loved the learning and education. I think probably the most valuable thing is the mentor protege relationship.
Yeah.
I know you love Seinfeld with
Yes.
Banyan and Seinfeld for the comedic roles. The mentor protege relationship is so important. I've had so many people who have mentored me over the years, and I've learned so much, and hopefully I can be a mentor for others. I've loved being a protege, and I'm still learning all the time, and I love mentorship. So I think that's probably the greatest thing you could do. I talked to Paul before. I have a group practice and have great associates, but I was a practice owner for about 5 years before, and I always thought it was tough for me to have a start point to start with associates. So in hindsight, I wish I would have started that earlier, but I went through that process, and it's worked out well in the long run. But that'd probably be the big one.
I appreciate you sharing that. What mine is maybe even just a little more niche. It's like I wish I paid attention to how insurance adjustments worked in my dental practice earlier. You use MyFitnessPal to track your calories for your body, and you can have a cheat day where you ever notice, Matt, when they put the calories on the menu at a restaurant, it just ruins all the fun, right? You were going to get the potato skins, and now it's 2,000 calories. And the joke there is if you do that one day, it's not a big deal. But if you ate like that every day, you would become unhealthy. And I wish that I had connected with someone like Dr. Mark Costas, my friend and mentor, sponsor, and said, hey, this is how insurance adjustments work. You should pay more attention. Because I did a lot of sweeping under the rug. Oh, we're busy. Work with my dad. These are the people in our community. And now, yada, yada, from Seinfeld in 2025, we're out of network. Doesn't mean being out of network is right. Doesn't matter being in network is right. I say, my quote is, don't drop plans, don't sign up for plans, but make a plan about your plans to maximize your happiness. So that's my contribution to the group.
Great advice.
So I want to thank everybody for watching in. So impressed people who stopped their day. You can learn how to get this recording, Matt. I'll let you go on to your next things. I'm going to see you in just 2 months out there. And thanks so much for generously sharing your knowledge with us today.
Thank you very much, Paul. Thank you to the Dental Nachos team. You guys are in great hands with Dr. Goodman and his leaders. So keep up the good work.
Awesome. Thanks so much, Matt. Have a great rest of the day.